So, good morning. Good morning, Ahmedabad. It's a beautiful city, nice riverfront. I went for a run this morning feeling totally rejuvenated. To begin with, how many of you were in the session yesterday? Because it's going to be a revision. How many attended the sessions yesterday? Brilliant. So, when me and Mayur were given this clinical scenario revisiting, we had two options. Either go very complex, and I had a list of things, mitochondrial diabetes or insulin resistance, which is not improving, lipodystrophy, or keep it very simple. In clinical practice, 99% of the things are ordinary, simple. If you're thinking of rare diagnosis, you are rarely right. It doesn't mean that you don't need to be aware of it. So we decided mutually that we'll keep it very simple. It will be a recap of what we went through yesterday, and then we'll let you interact. I did ask you questions yesterday to write down the answer. I didn't give you the answer because I wanted you to find it out. So without saying much, this is the beautiful Ahmedabad pictures. On top right corner is Brecon Beacons, which is not very far from where I live. Occasionally when I'm in an adventurous spirit, I go for a trekking over there. It's a beautiful place with no noise, pollution and clear skies. So similar to what we did yesterday, there is a clinical scenario. I'll let you read it. Based on what we went through yesterday, I want you to give answers. As I said, diabetes is a huge burden. Dr. Teed mentioned about, Prof. Teed mentioned about it's going to be 1 in 10 adult individuals having this, and probably more common in Southeast Asia. So rather than making things complex, we need to remember very simple basic principles related to its management. So a 47-year-old, should I call 47 old? I'll say it's 47-year young patient comes in. My definition of old is somebody older than me, so 47 is young, right? Type 2 diabetes, which was diagnosed 6 months ago, needs to be on metformin. Most of the guidelines say metformin, data supporting metformin use from UKPDS. If I compare it to the robustness of their data for CVD protection with metformin, I'll say based on the time and everything, it was good enough. We are not going to change metformin's position as the first line therapy. It's economical, it's time tested. Complaining of osmotic symptoms, BMI of 30, blood pressure of 150 by 90 millimeter of mercury. So these are the investigation results. Anything which stands out? Do you think the control is optimum? Triglycerides are high. LDL cholesterol is high. So, happy with the scenario? Had I given you a different option in which the BMI was normal, patient was younger, I would have asked you for type of diabetes. I could have asked you or tested you on, is it type 1, and I'll do the islet cell antibodies. You need to be aware of what is important in monogenic diabetes, what are the phenotypic features. I could have gone and asked about mitochondrial, in which there is a maternal kind of transmission, story of sensory neural deafness also running in generations, but I kept it simple. I could have asked you about C-peptide measurement, when to do it, how to interpret it, right? But we covered these topics yesterday, so coming on to it. I want a volunteer to come in now to help me out with this story, or couple of you. Target blood glucose, HbA1c. I've already individualized this patient. I've given you information, 47, fit enough, young enough. You tell me and we'll have a discussion about what should be the HbA1c target, how you want to control the blood pressure. Is there any difference in ambulatory blood pressure monitoring and home monitoring or in the office monitoring, and your targets for LDL. It's very simple message, but I think what I've learned in 3 decades of practice is if you keep the thing simple, it's easy to interpret the results also. So let's stick to the basics. Anyone brave enough to tell me how? Yep, you want to? Yeah. On this unit wise, Mayur, you want to say anything here?
Yes. So almost close. See, again we go back to the case. I would say just few more points I'll add here. So we have here, see the age, that is how you decide. So this is 47-year-old. Then whenever you see a patient, always reconfirm the diagnosis. Already we have made it very simple, type 2 diabetes, but you have to take into consideration other things also. And now we see all type of diabetes irrelevant of age. So type 1, all those young onset, all those things you need to see. Okay. Then this patient has some features of catabolism, so that you need to address. And very important, which we often forget in our clinical practice, is to ask about lifestyle modification. Whether the patient is actually following or not, whether the patient is following some dietary restriction or not, or whether the patient is eating sweets every day. Without that, kindly do not modify treatment very, very quickly. Okay. And then the compliance of the treatment, that also often we don't ask. And that is relevant for everything, whether you talk about diabetes, whether you talk about hypothyroidism, anything. So before chasing a target, please see whether the patient is compliant to treatment or not. That treatment includes lifestyle modification. So all those things are of practical importance. That is how we have created this. And sometimes, considering this higher BMI, even if you reduce it, then the patient may respond to same medication. And as you have rightly said, the target would be somewhere less than 7%. And what the standard guideline says is fasting somewhere 80 to 130, PP somewhere 100 to 180 is good enough. If you can make it less than 6.5 without hypoglycemia, that is also considerable, no issues, provided the patient does not land up into hypoglycemia. So that way it is good enough. And for the BP, the targets with the recent guideline 2 years, this has been changed to 130/80. Okay, so that is regarding that.
Ram wants to say.
Whenever I see a patient with high blood sugar, my first question is, when did you take your last dose of OHA or insulin? That's very essential. And most of my patients, they'll say, I'm using medicines regularly, and they'll say, I stopped 4 days back. They think 4 days is not a big time, which is very crucial. Thank you.
Totally agree. So compliance is something which you should be asking, and then the lab test. See, ultimately you cannot say by seeing a patient, okay, his sugars are that. So the standard, what the patient has got the report. In India, this is again very, very important. Whether you are getting this HbA1c from an HPLC method or not, that is again an important thing. Whether these sugars were done just by glucometer, which may be inaccurate, maybe he is using an expired strip, something like that happens. This is common in clinical practice. So all those things we have to keep in mind before prescribing anything. Just don't keep on seeing the report and change the medication. What is important is to treat the patient, not the report. Just remember this line. You have to evaluate the patient in toto. You cannot just treat a report, whichever he is bringing, right?
So I'll add on something interesting here, and thanks Mayur for reminding me. When I teach my specialty trainees or registrars in diabetes and endocrine, and especially coming from an era in which I took up the training 20 years ago, I usually considered diabetes as a boring condition because I thought, as compared to endocrine, the challenges for diagnosis are not as much. Now, if I share some stories with you, oldest patient with type 1 under my care at the time of diagnosis was mid-70s. Anti-GAD antibodies strongly positive in a 75-year-old. nothing will prevent autoimmune disease to happen second time in life. I've got Graves' thyrotoxicosis patient presenting in their 70s and 80s also. In fact, my mom has Graves' disease, which I diagnosed 3 or 4 years ago. So autoimmune disease have two peaks, one early in life. There is another resurgence later in life also, after age of 70. Just be mindful. Another important thing, latent autoimmune diabetes of adulthood, LEDA. Normally, if you go by the classic book definition, 30 to 50 age group, normal BMI. My question here is, what prevents an autoimmune disease to happen in a patient with increased BMI? Nothing. People with normal BMI or increased BMI are at equal risk of developing an autoimmune disease. So just because a phenotype suggests type 2, yes, you are likely to be right if everything else correlates. But if the patient has history of primary hypothyroidism, celiac disease, SLE, rheumatoid, something else, please think out of the box, right? So a very simple message.
Yeah.
And last thing, sorry, endocrine conditions. Occasionally, I've seen Cushing's presenting with high blood glucose, but there are other telltale signs there. And acromegaly once every 1 or 2 years.
Yeah, so there are now newer concept of dual diabetes. Somebody who is having type 1 diabetes, but now getting obesity also, right? So it's like both the pathophysiologies are going together, okay? Similarly, we have something called digenic body also. Somewhere two gene mutation, two allele mutation, which itself would have not caused MODY, but then two of them are causing that. So now the diagnosis is totally different and you have to evaluate in toto, and accordingly, that is what we are talking about, the precision medicine. Yesterday also we were talking about that. So depending on the diagnosis, the treatment would vary little bit, okay? So that you have to understand.
So next part now, we've done the targets, we've gone through the classification and diagnosis. What will be your therapeutic treatment option for this gentleman to improve glycemic control, lower the blood pressure, lower the LDL cholesterol? Very simple. As I said, you can make it complex if you want to, but as long as we are doing things right repetitively, we'll get better results. So, and there is no right or wrong, absolute right or wrong answer here, right? So what will be your second line option after metformin in this 47-year-old? Any consensus? Yep. SGLT2, yeah. And for blood pressure lowering, first line? No doubt about it, yeah. Lowering LDL and triglycerides? Statins. Trigs will not have as much impact with statin therapy. And we discussed about it, fibrates and omega-3 fatty acids. There is no CVD benefit at the moment except for that single molecule. And the molecule, icosapentaethyl, the evidence is driven by two trial results, JELIS, the Japanese study, and a REDUCE-IT study in 2018 or 19. And we are still waiting for final answers there. So correct. What about the GLP-1s? Why not? Or lifestyle? Why can't you change the course of this man's or person's life altogether? Use something which is disease modifying. So he's saying that he will probably go for insulin initiation. I think it will be
from Nepal. So since we have to see I always follow the RSD therapeutic wheel, A, B, C, D, E, F, G, H. So F means financial status of the patient. So in India, Nepal, and every country, I see the financial status. Because in Western countries also, the insurance is very important. So in this patient, since if he is from Nepal or Southeast Asia, first you have to see the cost. So if he is affording, we can go ahead with GLP-1 agonist. If it's not affording what this patient has catabolic symptoms, insulin will be the best therapy. Later on to reduce his BMI, SGLT2 is the best, and we have to decrease his weight, lifestyle, along with the lifestyle, stress relieving, sleep habits relieving, mental status, everything has to be there, and along with that, if affording, the GLP-1 agonist will be there. Thank you.
So again, a bit of revision from what we discussed yesterday. What will you do if he starts to develop diabetic nephropathy? Is your medication regime going to change? Are you going to stop metformin, SGLT2 inhibitors? Think about Finrenon. Yeah. Any volunteer for it? Yeah, Dr. Ram, coming to rescue.
If Finerenone is useful, we tried in some patients, but we added to SGLT2 and we got some good results.
So SGLT2 remain the treatment option. You can use Finrenon. You have to be careful about monitoring the potassium. You need to make sure EGFR is more than 25 to begin with, and monitor potassium after starting it also. Remember, we are dealing with lives here, and some of the most traumatic things you go through is if things go wrong in clinical practice. I've seen somebody develop liver failure with PTU, propyl thiouracil. It will haunt me forever, although it's extremely uncommon. So similarly, if you're giving Finrenon and potassium you're not monitoring it, a high potassium can lead to arrhythmias and sudden deaths. You don't want to end up with things which are more complicated. So fantastic.
I want to ask you, if the patients see that creatinine is going up, I think we have to add some other drug in addition to SGLT2, because SGLT2s won't work if the creatinine is high or EGFR.
Yeah, the only single point you need to remember, SGLT2's efficacy as glucose lowering medication reduces as the EGFR goes down, right? The efficacy as the non-glycemic benefits continue. So there are two aspects for glycemic improvement. In renal failure, my first choice, I'm talking about CKD stage 4 and end stage, is insulin. The insulin is metabolized in the kidneys, it stays longer, and these patients are vulnerable to hypos. I'm very careful about using sulfonylureas. I'm very, very careful. I'm not, you can kill a person with hypoglycemia.
Yeah, just to add for all the delegates here, whenever you see a patient in India, what we have in reports is just the creatinine. Please don't go with that. You have to calculate EGFR. So kindly make note that you have to calculate EGFR. Most of the reports will not be showing it. One important message from today's is calculate EGFR. If you see the trials, see if EGFR is beyond 20, above 20, you can use AMPA. Above 25, you can use both AMPA and DAPA. So we have trials for DAPA up to 25 and up to 20 we have for AMPA. That thing is to be noted. Then whenever you start an SGLT2 inhibitor, irrespective of your HbA1c, irrespective of your glycemic control, if the patient has a low EGFR, you have to initiate an SGLT2 inhibitor, and that is not because we want his sugars to be controlled. When I am saying irrespective, that means let's say a patient had an HbA1c of say 6.5, that is what you are targeting. Still you have to add, because you are not adding this drug for the glycemic control. In fact, when the EGFR goes below 30, the drug is not acting much as an anti-hyperglycemic drug. We are using the cardio and the renal benefit of this drug. Okay, so that's an important consideration. And then another very important concept to be discussed is, because this drug decreases the intraglommerular pressure, this will lead to a fall of EGFR at whenever you start, right? So let's say you have started at 20, the EGFR may fall by 5 further, and the patient can have a further worsening of creatinine. Your EGFR would be dropped to 20 to 15, something like that. Kindly do not discontinue. That's the starting point. It's not for discontinuing. If the patient is already on that drug, you have to continue, and there are data that definitely there would be a drop in EGFR. That means there would be worsening at the beginning, but in the long run, it would be beneficial for the patient. So that thing also you have to keep in mind, because these patients, whenever you say that, okay, your kidney is not working properly, that is why we are starting, probably the patient would get again creatinine after a week or so, and that would be worsened. So do not get afraid of it. That's a normal course, but in the long run, the patient would be benefited.
So another important point is, how do you assess somebody's insulinopenic? There isn't, anyone wants to shed some light on it? So, pardon? Fasting, postprandial, HbA1c test different aspect of glycemic control. Fasting, postprandial is normally the first one to go. Fasting more related with the glucagon and gluconeogenesis, and HbA1c is just the average kind of. With CGM we are learning a lot. What used to be defined as abnormal is within the remit of normal also now with continuous glucose monitoring. So anything else apart from fasting? So let's, pardon? Symptoms are important, osmotic symptoms. So if they are waking up multiple times in night to wee or feeling thirsty all the time. Anyone else? So the key thing you have to remember that type 2 diabetes patients may run out of their insulin store as the life progresses also. So if the glycemic control remains suboptimal, people are losing weight, muscle mass, it is a catabolic kind of state, right? So that again is a clue that people may be insulinopenic. So anyone for metabolic dysfunction associated liver disease?
Just to add, whenever you talk about insulinopenic, the first thing which I was looking for the answer is, look for the signs of insulin resistance which nobody mentioned. If you have a patient obese, BMI high, acanthosis nigricans, skin tag, probably patient have more of insulin resistance and is not insulinopenic. That is something you have to see. We see patients like 12-year-old or 15-year-old having type 2 diabetes, right? Earlier the concept was, if you're seeing a patient say 12 or 18 years earlier than that with diabetes, probably it is type 1. But now the concepts are totally changing. Somebody at 55 years can have type 1 diabetes. Somebody at 12 years can have type 2 diabetes. Though we don't have much drug, only 2 of the drugs are approved, that is metformin and recently the empagliflozin, which is approved at 13 years later. So these things you have to see, right? And firstly, as already told, see, treat the patient, just the basic thing. History, examination, followed by investigation. So history, features of catabolism, probably the patient have insulinopenia. Then examination, signs of insulin resistance, acanthosis, skin tag, BMI, all those things are important. And then followed by investigation. That is your C-peptide. But again, there are fallacies, right? If you get it at very high sugars, probably the C-peptide can be rock bottom. And maybe later on with controlled diabetes, the C-peptide can be again normal. So every report has some fallacies, every test have coefficient of variation, the same test repeated again can vary results, right? So all those things you have to keep in mind to arrive to a diagnosis.
So as we've got only 2 minutes left, I'll run through some of the slides here. These are the glycemic goal individualized target. That's for a fit, healthy individual. I showed you this algorithm yesterday also. That's from Diabetes Care 2025 Jan. It's ADA criteria. You can go through it, endorsed by ESD also. Very useful. You can, there are details in there which will be helpful in clinical practice. These are the blood pressure targets again, and I think we are providing you with some kind of study material, so I'm not going to repeat things in here. CVD risk categories, we did cover them yesterday. We did mention that type 2 with end organ damage, anything is high risk or very high risk. And duration more than 10 years for diabetes again puts them in high risk. So most of our diabetes patients are at high risk to begin with. LDL target we did cover yesterday again. I am not going to go through the things. So the LDL targets need to be more stringent. If people are having recurrent events, you need to keep it under 1 millimole per liter, which is around 38.5. And think about doing LP little a and think about the genetics of it also.
Any question from the audience? Also, I'll just move on to the last slide. Just to add a point, kindly take a picture of this, because this is something important. Most of the reports, whatever you see for LDL, the normal value would be written as less than 100, but that less than 100 is for non-diabetic normal patient, normal person, right? So whenever our patient, the diabetic patient comes, That is not normal for him. The normal values is this. Okay, that is what you are targeting. This is what you want. Not that less than 100. That is for population. That is not for a diabetic. So that is important to tell your patient, because once you increase the dose, probably somebody else would say that this report is normal, your LDL is coming 90, do not increase. So that you need to address, that you need to tell your patient.
Okay, thank you.